All right, I think we'll get started. It's my pleasure today to introduce two speakers to you. The first is very well known to all of us, and that's Dr. Kathy Mazzola. Kathy is our pediatric neurosurgeon at Goryev and has lectured many times. She's been a big supporter of pediatric grand rounds. And Kathy did her undergraduate work at College of Mount St. Vincent. She received her MD degree from UMDNJ, New Jersey Medical School. She did her neurosurgery residency at UMDNJ and then went on and did a pediatric neurosurgery fellowship at the University of Pittsburgh Medical Center. She's the director of the New Jersey Craniofacial Center. She has been extremely active here at Atlantic Health on committees, but in addition to that, is well known in New Jersey and nationally because of her involvement in various societies and committees and boards. She's been very active teaching students and residents. She has multiple publications in peer-reviewed journals, and again, has always been a good friend to pediatric grand rounds. She has asked another speaker to join us today, Dr. Gait. Gait received his BS, Master's, and PhD from the University of Denver, initially in computer engineering, and then his Master's and PhD in mechanical engineering. He's currently an assistant professor of at NJIT in the Department of Biomedical Engineering. He's very involved in clinical research, which you're going to hear some about today. And because of his involvement in research, he also has multiple publications in peer-reviewed journals. Today, the team is going to give us a talk on toe walking, spastic diplegia, hemiparesis, and gait analysis, assessing gait in an objective and analytic manner.
All right, so I'm going to open the share tray, and I am going to start my slide. So do you guys see the presentation now?
Yes.
Perfect. Okay. So thank you, Dr. Gregory, for asking us to speak today. It's my pleasure to talk with Dr. Powell. I have no disclosures. I became very interested in cerebral palsy early on in grammar school when I befriended this boy, Carl, who had dystonic cerebral palsy. I didn't know what it was at the time, but I became very interested in CP. And when I went to do my pediatric neurosurgery fellowship, I decided to go to Pittsburgh because they had a huge pediatric movement disorder center, which I wanted to replicate when I came to Morristown in 2005. So the objectives for today's pediatric grand rounds are to discuss gait patterns in normal children and those with gait disorders, to talk about some of the treatment options for children with spasticity and abnormal gait patterns, and to explain how objective data analysis may change our practice patterns. And for me, this is very important. I spent probably about 15 years, and I'm still involved with pediatric neurosurgical practice guidelines. And I really do believe in evidence-based medicine. And so through the talk, you'll hear about the Gait Lab and how this really brings evidence-based medicine and guidelines to the forefront. So first, let's talk about movement disorders in children, right? So you can have children who have hypokinesia or hyperkinesia. They have less movement or more movement. You can have children who are weak or floppy and hypotonic, or you can have children who are hypertonic or tight, spastic, or rigid. And you know the movement can either affect an arm, both arms, both legs. So it's important to describe the laterality of their movement disorder. And you also have to describe how prevalent the movement disorder is. Does this happen all the time, or they have dystonia part of the time? So how we describe movement disorders in children is a very subjective evaluation. Spasticity, which most of you have heard about before, is looking at the velocity dependent increase in tone. So as you range that child's arms or legs, you feel their arms or legs getting tighter. So spasticity can be localized to both arms and both legs, and then those children are called spastic quadriparetic, or they can have spasticity or tightness in both legs, spastic diplegia, or they can have one arm spared, or they can only have a limited involvement of tightness in spastic monoplegia, and that usually can happen after a stroke or a focal event in the brain. But spasticity left untreated causes flexion contractures across the affected joint, and that's why it's important to treat spasticity. So spasticity is the most common movement disorder in cerebral palsy, and it causes a hypermetabolic state that increases the basal metabolic rate for the child, which causes weight loss and cachexia. So if you look at the picture at the bottom right, you can see how thin and cachectic this child is who's had untreated spasticity, and how skinny he is and how scoliotic he is. So spasticity affects the activities of daily life. It significantly limits the child's mobility. It can cause reflux and other swallowing and eating problems. It can cause the child to wake up throughout the night with pain and spasms. It can lead to DVTs and D-cubes, scoliosis, and neurogenic bladder and bowel syndrome. When we look at a child with a spastic gait, you will see later, and that you've seen in your practice, that these children don't walk as fast, that they have a shortened stride length, that they have crouching at the waist because of hip flexor spasticity. They have increased knee flexion, pelvic tilt. Some of these children will have scissoring and toe walking, as you can see in the picture in the bottom left. That child is up on their toes with in-turning of both feet. These children have difficulty in initiating steppage. They have decreased overall range of motion, and it is a lot of work for these children to walk. They have to struggle, and because of the struggle in overcoming the spasticity, it causes increased effort and increased energy expenditure. Now, toe walkers are a completely different group of children. So many children toe walk, and most of them do not have cerebral palsy. For most children, this is a pattern behavior that they cannot necessarily control. So it's almost more behavioral. But one of the things that we're talking about is the treatment for toe walkers in some cases is very similar. If you look at spasticity or CP, spasticity and CP are often caused by stroke, hypoxia, or anoxia, which causes brain damage. Some children have cerebral palsy from head trauma as an infant or as a toddler. You can also have children who have spinal cord injury who develop spasticity, or brain tumors or infections. And we also have a group of children who we treat who have genetic spasticity called hereditary spastic paraparesis. So that's a different kind of spasticity. The diagnosis of spasticity is all clinical. You can't do an X-ray to diagnose spasticity. It doesn't show up on a CT scan or an MRI, although you may see periventricular leukomalacia from the hypoxic event in the perinatal period. You can't even diagnose spasticity necessarily on an EMG. It really is clinical examination. So when I was in Pittsburgh, we were always talking about the modified Ashworth scale, which was described in 1964, where a score of 0 means normal, no increase in tone when you range that extremity. Whereas a score of 4/4 meant that there was a contracture at that joint. You could not range that child. So the Ashworth spasticity score is based on 1 to 5, where 1 means no tone and 5 is a fixed contracture. And the modified Ashworth scale is 0 to 4. So already you can see it's a little bit confusing because some doctors talk about the modified Ashworth scale and other doctors talk about the Ashworth scale. But we all agree that some children have no tone and they're normal, and some children have significant spasticity and may go on to develop contractures. Now, the gross motor function classification system, or the GM-FCS, is different. The gross motor function of children just with CP describes 5 different categories or levels where they look at movement, such as sitting and walking, and the use of mobility devices, such as a walker. It's helpful and maybe more helpful because it provides families and clinicians with a better description of the child's current motor function, an idea of what equipment or mobility aids a child may need in the future. For example, will this child need crutches, a walker, something like that, or a wheelchair? And generally, a child over the age of 5 will not change their GM-FCS, so that if you have a child who's a level 4 at age 6, that is pretty much their prognosis for the rest of their life. So a GM-FCS level of 1 is basically pretty normal. The children can walk at home independently, outdoors, and in the community. They can go up and down stairs without assistance. A GM-FCS level 2 is where children can walk in most settings, but they may have difficulty walking long distances. They may have difficulty with balancing on uneven terrain. They may have difficulty with stairs. And they have just minor spasticity. If you look at GM-FCS level 3, these children usually can walk using a handheld walker, and they can walk in most indoor settings. They may be able to climb stairs holding onto a railing, and they use typically a wheelchair when traveling long distances, and they can actually push their own wheelchair for shorter distances. Some of the more affected children with cerebral palsy, GM-FCS level 4, these children use methods of mobility that require physical assistance or power wheelchairs in many settings. They might be able to walk at home or at school with a lot of support, but basically they're using a powerized wheelchair that sometimes they can control with a hand device. GM-FCS level 5 children are usually transported in a manual wheelchair in all settings. They're very limited in their ability to maintain anti-gravity head and trunk postures, and it's very difficult for them to control leg and arm movements. So there are many problems with the clinical descriptions of children with cerebral palsy, obviously, because it's very subjective and it's very temporal. So I might see a child and say, well, this child is level 3, and in a different environment, that child may appear to be a level 2. So it's very subjective. So gait analysis. In the past, doing a gait analysis for a child with cerebral palsy was very, very expensive for the parents, and many insurance companies did not pay for gait analysis. So the parents had to pay for it. And in order to send the child for a gait analysis, they would have to go to Shriners Hospital or a hospital further away. And that would be hours of traveling time for their families. And it was very expensive for them. And then these gait analyses had to be repeated, and the children should be reevaluated with age. So for example, if you had a 3-year-old who had untreated spasticity, as their gait deteriorated, if you did their gait analysis at age 5, it would look very different because now they have more contractures. Now they're more affected by their spasticity. And then if that child went on to have a dorsal rhizotomy to reduce their tone, or if they had Botox, or if they had a tendon lengthening, you'd like to do, ideally, a new gait analysis to see how that child improved, hopefully, and you could actually look at their gait after an intervention. There are so many different treatment options available nowadays for children with spasticity or dystonia. So there are oral medications, and these medications are typically started around 2 to 4 years of age. Medications such as oral baclofen or Valium or dantrolene, and Botox injections can be done with or without EMG guidance with alcohol blocks. And the Botox and the alcohol blocks, although I was trained to do them in Pittsburgh, the alcohol and Botox injections are more typically done by a child physiatrist, someone who follows the child throughout their life and works with us to reduce tone in their legs and in their arms. There are surgical therapies such as intrathecal or intraventricular baclofen, and you've all heard of the baclofen pumps. The selective dorsal rhizotomies I've spoken about several times, and deep brain stimulation, where you actually put a wire or an electrode into the brain to stimulate the brain, is more often used for children with dystonia. Orthopedic surgeons help these children by doing tendon lengthenings and also derotational osteotomies and hip reconstructions in those children who've developed hip subluxation from untreated spasticity. And our physical therapists, they usually get involved, and we usually start orthotics for these children as early as 1 year of age. So our physical therapists and our orthotists work hand in hand with us all the time. So about 3 years ago, I became involved with the New Jersey Institute of Technology, and the initial research that I did with NJIT focused on looking at CTI, MRI in children with concussion and ADHD. Although that was my initial research projects, I then went on to meet Dr. Saikat Pal, and he was in the process of building a pediatric or movement disorders lab, and I became very involved in the research that we're doing there with children with cerebral palsy. I'm going to hand the presentation over in a minute to Dr. Saikat Pal, but I wanted to give special thanks and a shout out to Dr. Jenfu Cheng and to Dr. Idobar Osula. We have our lab meetings twice a month now, where we literally spend 2 or 3 hours reviewing the data from the patients, where we've done gait analysis and discussing the results and helping Dr. Pal. So I am going to end the show, and I am going to go back here, and I'm going to stop sharing and open it up to Dr. Saikat Pal.
Thank you, Dr. Mazzola. Hi, everyone. This is a disclaimer, my first grand rounds ever. I'm an engineer, so it'll be a good learning experience for me. So I'm going to start sharing my slides. Okay, Kathy, are you able to see my slide?
Yes.
Okay, so as Kathy mentioned, I'm an assistant professor at the New Jersey Institute of Technology. I've been here for a little over 4 years now. My background is in human movement biomechanics. So I'm primarily interested in how we move and how the human body acts as essentially as a mechanical device, and where we have the motors, where we have the parts, the gears. So I look at the body as a mechanical system. So this specific project, as Kathy mentioned, it's a very collaborative project with Dr. Mazzola, Dr. Chang at the Children's Specialized Hospital, and then Dr. Rasula at the Rutgers University Hospital. And everything that I show over here is the work of my students. So I do want to give a huge shout out to my students in the lab who do all the work. I have no financial disclosures. One thing is that we will be discussing the use of botulinum neurotoxin, which I believe is an off-label use. Kathy, can you confirm?
In some cases, it's off-label. In some cases, it's on-label.
Okay, thank you. I wanted to introduce. I wanted to spend a couple of minutes talking about the motion capsule lab that we've built in the last 3.5 years. It's located in the Life Sciences Engineering Center at NJIT. Here's the basic layout. It's essentially a big space where we can do a broad range of experiments. So here's another picture of the lab. As you can see, we have a big open space. It's around 1,500 square feet. We've got 16 cameras, and then we have a nice instrumented treadmill. So I'm not sure if there are people in the audience who have a background in motion capture or in gait analysis. But for those of you who are new, essentially what we do is we use infrared cameras, and we put balls or passive markers on subjects, and then we track the markers. That gives us a relative, essentially 3D dimensions of where the body segments are while they do different activities. Here are a couple more pictures. This is a Burtick instrumented treadmill. What this gives us is ground reaction force. So it gives us an idea of how hard the person is pushing on the ground. There are typical gait curves for healthy adults, and then if you have musculoskeletal disorders, or for example, children with cerebral palsy, we see very different ground reaction force data. So it gives us another metric to evaluate the underlying mechanism. Some of the equipment we have, these are infrared cameras. So essentially, this is critical. This is how we measure the movement. We also have a couple of video reference cameras. So we want to be able to actually see what's going on. Most of what I'll be presenting today will be the output of the video cameras. There'll be one or two slides where I'll show you the product of the reconstruction of what the Vicon cameras are giving us. I mentioned the treadmill. One good thing about having a treadmill like this is we can do some very dynamic studies. So we can have a person walk, we can have a person jog, run, sprint without the need for a large space. We don't need a stadium to conduct these studies. We can do it all in our lab. We can even have a person run a marathon on a Burtick treadmill. Then we have a 16-channel wireless EMG system. And then we have a whole host of wearable sensors that are becoming very popular these days. So now going to clinical gait analysis, what we do, the way I look at our collaboration is essentially I provide a service to the clinicians. I provide a service to Dr. Mazzola, I provide a service to Dr. Chang and Dr. Rasula. They refer children with CP to us. My students, we analyze them, and these are the metrics that we look at. We essentially quantify the changes in gait due to cerebral palsy. And we do that by giving specific quantitative values in terms of gait deviations. There are several metrics for gait deviations. The popular ones are the gait deviation index, the movement deviation profile, and then a gait profile score, and then a couple more. So essentially what gait deviation does is that it gives the clinicians like Dr. Mazzola one number if they require or more detailed analysis. So you could essentially, we could essentially quantify if a person comes before, let's say, a Botox surgery, we can give them one number for their left side, one number for their right side, and then we evaluate them after their surgery, and we look at how the number has changed. Increased, decreased, is it tending more towards typically developing? So essentially, we take away the subjectivity from the analysis. The second metric over here is joint kinematics. Kinematics is essentially joint angles. For example, when we walk, we have very typical knee flexion angle curves. And for children with cerebral palsy, those curves deviate quite a bit. So we can quantify every single limb. So we usually do the lower extremity, so all the way from pelvis to the foot. We will analyze all the joint angles, and then essentially, if a clinician is interested in looking at a specific joint, they can look at the joint kinematics and see what's going on. As I mentioned earlier, we give ground reaction forces, and we can evaluate the effects of clinical interventions, or even at baseline how different they are from typically developing children. And muscle EMG is a good indicator of some of the underlying conditions. EMG has been used for a long time to try and understand some underlying symptoms. In CE, we can look at spasticity, or we can look at high tone by looking at the activation patterns of EMG. And then, as Kathy mentioned earlier, we look at essentially the effects of clinical interventions. So we get patients referred by our clinical partners, and so far we've done mostly a combination of these. AFOs, or ankle foot orthoses, are fairly common in kids with CP. We evaluate them with and without AFOs. We look at the effects of botulinum neurotoxin. We've done a little bit of tendon lengthening, not a lot. We've done a few cases of dorsal rhizotomy, and then baclofen pump. So this is not a complete list. Kathy had a more complete list, but essentially we look at how these clinical interventions affect or change or hopefully improve gait in children with cerebral palsy. So before we look at show some of the videos, here's a typically developing child. So in addition to children with CP, we need to have a baseline. We need to understand what typically developing children, how their gait pattern looks, and so we also recruit children with typically developing children and bring them in our lab. So if anyone has kids and you want to volunteer your children to be part of the study, we would really appreciate it, because with COVID and everything else, our recruitment for typically developing children has been fairly difficult. So it's a priority for us to evaluate our methods against the gold standard. The gold standard would be typically developing children. So now looking at CP Gait, I will show you a series of videos, and the videos are going to go from high functioning kids to more and more progressively difficult cases. So this is a patient who is a 16-year-old child. She is spastic monoplegic. Her affected side is her right side. So you can kind of see that she looks, her gait is very, very similar to typically developing children. Especially on her left side, you see no differences, but then on her right side, you do see, if you look close enough at the toes and the feet, you see a little bit of difference. So this is a slightly more, I would say, poor functioning case. In this case, her scale is, her GMFCS scale is 2. She's a 7-year-old patient. She's spastic diplegic, so essentially both sides are affected, but she's able to walk on her own. So one thing that we see very well in our lab is high functioning children with cerebral palsy. They are able to navigate the treadmill. They figure it out. The treadmill is new to most of the patients. Many of them struggle on it, but it's usually a good distinction is essentially their GMFCS score. Ones and twos, they're okay on the treadmill. Anything more than that, they're unable to walk on the treadmill or navigate the treadmill. So here's another subject. This person has a slight crouch gait. It's a 9-year-old spastic diplegic patient. So for the most part, he's doing great on the treadmill. He's able to control himself. He's able to walk. He's able to navigate the split belt. It's good. So now we get to some more of the patients who have GMFCS scores of 3 or more, where this patient over here is unable to walk independently. He needs crutches, so that becomes difficult on the treadmill, but also even with the crutches, this person was not able to navigate the treadmill. However, we have the option of we also have the lab set up for overground. So we collect overground data for this person. We have overground data. Okay. So here's another person who uses a walker, and she's an 8-year-old, GMFCS score of 3. As you can see, the gait patterns are substantially different than typically developing children. So now the next couple of slides, I'll talk about AFOs, ankle foot orthosis. We bring in children who do use AFOs. We evaluate them with and without the AFOs to look at how the AFOs or are the AFOs doing what they are supposed to do. This is a child who is hemiplegic. The video on the left is going to be bare feet without the AFO. Kathy, please jump in whenever you want.
Right. I think that doing this is actually very helpful because we can actually see if we're recommending an AFO, if that AFO decreases the energy needed to walk and improves their gait pattern. So it's very easy for us to look at before and after AFO.
So this is a particular pattern, right, Kathy? You mentioned in your talk about the foot strike on the right side, and we can clearly see that this person has almost no heel strike without the AFO. And then
right.
we look at the next.
We have some of our pediatric orthopedic surgeons on, who are watching. So Barbara and Ellen, if you have any questions, feel free to put it in the chat box or just unmute yourself.
So now with this child now has an AFO on for just his right leg, and you can see the transition or essentially from swing to stance. You do see a heel strike pattern now. In this case, the AFO clearly makes a difference in bringing this child's gait more towards the typically developing range. So here's another case. So the top video is bare feet. And you can look at the little bit of crouch at the knee joint and at the hips. And this person is diplegic. So the bottom video is with AFO. And now with the AFO, the person does not really even need crutches.
Right, and I think it's important to look at gait with and without the AFOs, because very often as, pediatric subspecialists will recommend an AFO, and the child will report that they don't like wearing the AFO and that they don't walk better. But when we actually show them the video and explain to the child or the parent how much better the child walks with the AFO, and encourages and reinforces AFO utilization. You know, a lot of the kids don't like to wear the AFO because they feel it makes them look different, but if you show them how well they walk with it, they can actually see the difference.
Okay. So next, this is a case of a person who we evaluated pre-botulinum and post. Is there a question? I'm sorry. Okay. So this is a case with pre-botulinum intervention and post. And here's a case where we clearly saw a difference. We were able to quantify the differences or quantify the improvements in gait. So this was in our temporary space. So the lab setting is different. Now this is our permanent lab. So now, once this person got the botulinum intervention, the data that I'm showing you is for their self-selected walking speed. But after the injection, so this person got injected in their gastroc muscle on the right side. So on the right side, and he was able to do a lot more activities on the treadmill. He was able to go at a faster pace, as well as he was able to jog on the treadmill, which he was not able to do in his pre-intervention. So what we do is we essentially evaluate the entire gait, and then, as I was mentioning earlier, GDI is Gait Deviation Index. So we can summarize the whole gait pattern into one value for the left leg and one value for the right leg. To orient you, so on the x-axis you're seeing 4 bars, 2 bars for the 2 bars for the left leg pre and post intervention. So this is pre-intervention left leg. This is post-intervention left leg. This is pre-intervention right leg, post-intervention right leg. And what we are shooting for for the GDI is we want to score as close to 100 as possible, because typically developing children, their scores range from around 95 to 105. So essentially the average for typically developing children is 100. The closer you are to 100, the more normal or the more close to typically developing gait you are. So initially this person started out with the left leg and the right leg hovering around 74, 73, 74-ish, and we collect multiple trials, so we collect as many trials as we can. So these error bars are standard deviations from each of the trials, or basically averaging the trials, and then we're getting the standard deviation. And then post-intervention, we see essentially a significant difference or a significant improvement in this person's gait. And we can quantify that. We can say that, okay, this person has improved around 10%. So this is essentially what our lab is doing. Is we are able to bring in the subjects. We're able to quantify: do you get 10% better? Do you get 20% better? Do you get 50% better? Or do you not get better at all? Or the nightmare situation is, do you get worse with all these interventions? Kathy, is there anything else you want to add?
No, but I think this is also a good example, Sai, where although the child has right spastic hemiparesis, how the left leg is also affected. So even in kids with a hemiparetic gait, the left leg has to compensate and then becomes abnormal.
Right, that's a good point. Okay, so so my research is essentially broken down into 2 components. The experiments, which I've shown you, the last several slides were experiments, but I wanted to show you one slide on the other half of my work, which is developing subject-specific computational models. So here's a child with cerebral palsy. You're seeing the video of the child walking on the treadmill. The middle figure is the real-time avatar. So as you can see, these dots over here, these dots are what the cameras are tracking. And then based on the location of these dots, we create a real-time avatar of this person. So while she's walking, there is this avatar that's walking with in the computer. And then we take this data and then we develop these. So the animation on the right is a subject-specific musculoskeletal model. So it's got the model is essentially scaled onto according to the subject's anthropometry, and then we have all the muscles of the lower extremity represented. So the goal is to use these computational methods to have some predictive ability, or to be able to gain some deeper insights that are not possible using experimental methods. So for example, in biomechanics world, in my world, I'm really interested in what are the forces that are imparted at the knee joint and the hip joint during crouch gait, for example. So we know that in crouch gait, both the antagonistic muscles are activated. And so as a result, there are greater loads at the knee joint than someone who's able to walk upright. And what is that continuous larger loads doing to the cartilage of these children? So some of these questions we can never answer with just experimental methods. We will have to develop these computational models, and we'll have to develop good estimates of what's going on with in terms of muscle forces, joint reaction forces, and be able to see if there are ways that we can predict the outcome of treatments. So a model like this could easily look at what the effects of tendon lengthening would do to the biomechanics of this person's walking. So we can go in there and we can adjust or simulate the effects of tendon lengthening. So essentially shift the force length property curves of that muscle to essentially understand what's going on. So that's
right.
basically, so go ahead.
Sai, I think, we don't have enough data yet, but eventually when we do have enough data, we'll be able to create predictive models so
Yes.
that we could see what effect Botox injections or tendon lengthening or derotational osteotomies or dorsal rhizotomies will do for a certain child's gait. So one of the things, that we really need more data, not just for the normal developing child, but for the spastic diplegic children who have not had Botox or lengthenings yet, because we need more data in the spastic diplegic naive children, and then follow them over 10 years after Botox, after tendon lengthenings, so then we can create more predictive models. But that will be us hopefully in 5 or 10 years.
Right. Yes. So it takes time to get the N that's required for some of these statistical models.
Right. Sai, there was there were two interesting questions. One was what would be the impact of pubertal growth spurt in these children? And basically, I said, we would be following these children annually to see if they're untreated, how their gait deteriorates. And the other question was, will scoliosis affect the gait pattern? And I believe that it does, but again, that data will be captured as we go forward in the future.
Yes. Okay, thank you. So those are basically the slides that I had. I mean, I'm going to open this up to questions now, but also to highlight that we are always looking for meaningful collaborations. A lot of science these days, if you want to accelerate and if you want to really make an impact, we understand that we need collaborations. So some things that I'm open to collaborating is if you have any needs for quantitative evaluation of human movement, if you want to look at the effects of injury prevention. So my lab is also teamed up with the Department of Athletics at NJIT, and we are tracking or we are keeping understanding the biomechanics of the different teams pre and post season. If you work with assistive devices like AFOs, or we've started doing a whole bunch of work on robotic exoskeletons, or other clinical ideas, or other ideas where you might find that a gait analysis of a particular population would be useful for you. So we would be happy to collaborate in these areas.
Right.
So,
And right now, Sai, the IRB that we have, can you explain what the IRB covers and what would be the IRB process, for example, if someone was interested in working with you to develop an IRB approved study for children who are behavioral toe walkers? One of the things that Zhenfu Cheng and I were talking about recently is perhaps we should write an IRB to look at children who are toe walkers before and after AFOs, before and after Botox, before and after physical therapy.
Right. So the IRB, or Institutional Review Board approval, is necessary for any human subject experiments in this country and in most parts of the world. At NJIT, if the work is going to happen at NJIT, then the NJIT IRB IRB panel is going to be involved. We'll have to get it approved through the NJIT committee. The way it works is that we apply, we have an experimental protocol, we have to demonstrate that we are qualified to do the work. Then there is the CT training, essentially training in responsible conduct of research. That's, I believe, standard for all. I mean, clinicians have to do it as well. We researchers have to do it as well. So once we have the clinical certificates or the training certificates, and then we have the experimental protocol, we show that we disclose the risks of the study. So most studies that we do, for example, the CP Gait study, risk to the children are slightly more than minimal, but they're not excessive. We are not puncturing the skin. We are not essentially, we are not doing anything that's irreversible during this process. So the study that Kathy, you just mentioned, it would be similar amount of risk. So it needs to get approved by the review panel, and then we'll have to track every single case. There's a consent form. The consent form needs to be signed by, if it's a pediatric population, then the consent has to be signed by the parent. But then there's an accompanying assent form that has to be signed by the kid or the child. And then we track, we keep a record of these subjects coming in, and if there's an adverse event, then we have to report that to the IRB committee, and it's a yearly review process.
Sai, a few things. I don't know, from your screen, can you show the website that you have created, and
Sure.
Eventually, maybe you could share the invitation for the ribbon cutting for the lab. And while you're pulling it up, I have some questions from the audience. Number one, from Dr. Meltzer. Dr. Meltzer would like you to explain a little bit about your work on the robotic exoskeleton, and does that work for children who are severely impacted? And then Dr. Khan wanted to know, is NJ's IT's program, have you been working on retrofitting vehicles for children or adult, teenagers or young adults who are ready to drive but could have neuromuscular or musculoskeletal differences? So two questions about the robotic exoskeleton and driving with these kids.
Right. So so hopefully everyone can see my screen. So this is the website for the lab. So I can show you the CP page. Well, these are the different projects that are going on. Okay. I can I can share the link for this website. I mean, it's probably best that we can all check out the website on our own. But going back to the exoskeleton question, unfortunately, well, exoskeletons are new. They have only been around for the last 10, 15 years. The unfortunate reality is that a lot of the innovation is not happening in the pediatric population. A lot of the innovation in exoskeletons are happening in the military world and then in the SCI or the stroke populations, because I mean, the reality is that money drives innovation in this country. And that's where a lot of the money is. So, but eventually we will get to the point where, so what, if you can see my screen, this is a robotic exoskeleton that is designed for SCI. It's the ReWalk P6 device. We have one of these devices in our lab, and we are doing extensive testing. We just got a grant to bring into get 2 more exoskeletons, the Bionics Exo and the Parker Hannifin Indigo, but these are all for adults. There really isn't, as far as I know, maybe I'm wrong, an FDA-approved exoskeleton for the pediatric population. All 3 exoskeletons that I mentioned, they're all FDA-approved for SCI use for rehabilitation of people with spinal cord injury. So that was the first question. Kathy, what was the second question?
The second question is, or maybe it's even more of a suggestion, that NJIT eventually start working on retrofitting vehicles for those patients who are ready to drive, but may have musculoskeletal or neuromuscular problems.
Right. So the Children's Specialized Hospital already does that. They have a whole lab dedicated to retrofitting assistive devices for children. I mean, if there's a really good need, then we can look into creating a pathway at NJIT. But if the Children's Hospital has it, then it doesn't necessarily make sense for us to duplicate that.
And the last thing I would say, Sai, is, and for the pediatricians and developmental pediatricians and neurologists and orthopedic surgeons who are on the call, is that if you have any, clinical interest in doing research, NJIT, the biomedical engineering department, is amazing. They have so many different projects going on, and they are always looking for clinical collaborators. So, Sai, before we close, do you want to mention some of the, well, you probably have hundreds of research projects going on in NJIT, but do you want to talk a little bit about some of them?
Yeah, I mean, I think I wasn't prepared to talk about all of NJIT, but we are a technical school. We specialize in engineering and technology, and for BME especially, I personally think that I'm lost without clinical collaborators, because I could sit in my lab and design all kinds of gadgets and tools and simulations and until I die. But if there is no impact of these, if you clinicians don't use them, and if it doesn't improve anyone's lives, then I've just wasted my life. So for me, it's critical that I collaborate with Kathy and Jenfu Chang and Dr. Asula, and essentially people who are actually interacting with the subjects, people who are going to directly benefit from this work. At NJIT, we have all kinds of research. So as Dr. Mazzola mentioned, she started out with working with a faculty member who does imaging, brain imaging. We have a big imaging core. They look at concussions. They look at all kinds of impacts. So traumatic brain injury is a big research focus at NJIT. We look at a whole bunch of stem cell stuff. We look at tissue engineering. We've got a couple of pretty renowned tissue engineers who essentially develop cartilage or biological tissues for many applications. My background is in orthopedic biomechanics. So I did my PhD in designing a knee replacement system, and that's where I got my start. So if there are people who are interested in orthopedics, that's something that I would love to do more because I don't do that much. I'm busy with I keep myself busy with the motion capture lab, but some of my passions are in trying to figure out how we can design better orthopedic devices or design the tools for more accurate surgeries. I don't think I've done a good enough job in explaining all the research that goes on at NJIT, but there's a lot happening, and the BME department. Our core mission should be that we develop or we innovate and build technologies that are in collaboration with you clinicians, because then you can use those developments directly in your work to improve lives.
Right. So, if any of you have any research ideas, feel free to go to the NJIT Biomedical Engineering website. They have a great website. If you see any projects that you're interested in, or if you have an idea for a project, you can always contact someone through the website or contact me and I'll put you in touch with someone. But NJIT is always looking for clinical collaboration. So that is it. I'll check one more time, see if we have any more questions, and no, we're good. So I will hand it back to Dr. John Gregory. John, you want to take it?
Yep, no, that was great, Saikat and Kathy. That was a really fascinating presentation. So appreciate your time.
Thank you so much. And thank you,
very much.
Saikat.
Thank
I'll
you
see you soon.
Bye.
Take care.